Good afternoon, and thank you for joining us for today's webinar on transitioning to adult care. My name is Caroline Lumpkins, and I'm the Education Programs Coordinator at NORD. It is my pleasure to be your host for today's webinar on transitioning care. This event is part of our free series of educational webinars for patients and caregivers. We are so glad that you were able to join us today. Today's webinar is brought to you with support from Astellas Gene Therapies. Before we get started, I would like to provide a brief word about NORD. For over 30 years, NORD has led the fight to improve the lives of those with rare diseases. We do this through education, research, advocacy, and patient services. To learn more about NORD or to access our resources and events, please visit our website at rarediseases.org. You can also follow us on Instagram, Facebook, and Twitter. This webinar is recorded, and we will make it available to all registrants in the next few weeks. At that time, please feel free to share it with anyone who was not able to join us today. And now I would like to introduce our speakers. Dr. Marvin Nitovich is a clinician and scientist at the Cleveland Clinic and the Cleveland Clinic Lerner School of Medicine of Case Western Reserve University. He is also chairman of the board of the Autism Research Institute and former co-director of the New England Regional Genetics Group. His clinical practice is in the fields of medical genetics and laboratory medicine. As a medical geneticist, he is involved in the evaluation and care of children and adults with developmental or neurological conditions that are thought to be of a genetic or metabolic basis. Max Starnes is a graduate of Lynn University in Boca Raton, Florida, with a BA in multimedia journalism. He pursues work as a content creator via photography and videography, and serves on the board for the Florida Family Leaders Network. Also a ventilator graduate from childhood days, Mac lives life to the fullest while embracing his rare condition that requires living with a trach and G-tube and the use of assistive technology to support his unique communication style. Linda Hampton Starnes brings over 30 years of expertise as a longtime advocate for persons with disabilities, utilizing her background as a former special educator, federal government appointee, service on multiple healthcare, disability, educational, and faith-based boards, and more recently as the statewide family leader with Florida Department of Health CMS Title V office. However, her most rewarding times come from the lived experience as a parent of two with very different and rare conditions, varying abilities, complex medical care needs, and all-around terrific people. And last but not least, we have Julie Corder. Julie is a pediatric nurse practitioner at the Cleveland Clinic Children's Hospital. The majority of her career has been spent caring for children and youth with chronic medical issues, including 25 years in pediatric nephrology and renal transplant. In 2015, she was part of the team who developed the Pediatric Complex Care, a PCMH for children with multiple chronic health concerns and dependence on technology. Transition has been an issue she has strongly advocated for throughout her career, and she currently works with the team at the clinic to formalize this process for all young adults. Our panelists have a lot of great information to share with you all today, and we will address the questions submitted during the registration period. With that, I am pleased to turn it over to Dr. Nitovich.
Thanks very much. I'm really pleased to be here today. And my purpose on this panel is to provide a general overview about some general medical perspectives relating to transitions of persons having rare conditions, especially in the transitional period and going from pediatric care, pediatric years to the adult years. Now, in serving on this webinar, Carolyn mentioned my background professionally, which is relevant, but the other piece of my background that's also relevant in terms of informing my perspectives with respect to this webinar is that I'm the parent of a wonderful young adult who's recently undergone the transition in healthcare from the pediatric years to the adult years, who has multiple significant disabilities. Now, in talking about healthcare transitions, one important truism is to recognize that as individuals and as families travel through time, there are multiple types of transitions we experience, and there are a number of different reasonable and important ways that one can consider these transitions. For example, there are biological and medical transitions, and these include such entities as the transition in a child going from the birth hospital to home, or for a child or for an adult who doesn't have a diagnosis, and the transition to a time when the person does have a diagnosis, or as is the subject for today's webinar, in going from pediatric care to adult care. And just as one can categorize transitions in terms of biological and medical transitions, there are also social, educational, and work transitions that are very important. So again, for example, there's the aging out of the school system when, for example, one might achieve the age of 22, or changes in one's health insurance coverage or in the family's health insurance coverage is another type of very important transitional entity. And changes in employment status of one or more members of a family are types of very important transitions that can impact on everyone in the family. A third category to consider are family transitions. And so, for example, if there are additions in a family or subtractions in the composition of the family, or as the family ages, all of these types of transitions can have great relevance to anyone, but especially a person who has an ongoing clinical condition. Now, the issues that we're going to be talking about today are numerous, and some of them are very particular. What I will be doing is to provide a general overview for some of the more common problems and most important considerations, but to cover everything is not possible and certainly beyond the scope of a 1-hour webinar. So if one were to crystallize the central or fundamental area of concern for us today, that is the care of a person who has a rare and or complicated clinical condition. And immediately, one can appreciate that there are going to be some central challenges in the clinical care of such persons at any time, but especially during the transitional care from pediatric years to the adult years. And let me explain several of them. First, medical staff are differentially available, and there may be limited numbers of persons, and sometimes no persons of appropriate clinical competency who are in the area where the person with the rare condition may be living. This is especially true, for example, in rural areas. Or there may be available medical staff to provide clinical care, but those medical staff may not lack adequate knowledge about the rare clinical condition, or they may be unwilling to assume care because of the complexity of the condition or because of its rarity. Another type of challenge that confronts persons having rare clinical conditions is that the emergency department and general hospital facilities may not be very comfortable or good fits for the person's clinical condition, and their culture similarly may not be a good fit for the needs of the affected individual. And then finally, another major challenge, again, irrespective of one's going through a transition from the pediatric years to adult years, but certainly at that time as well, concerns the medical insurance system, which, as we all know, in the United States is a patchwork system of variable cost and accessibility and of variable coverage. These challenges have multiple impacts. They have impacts on the affected individual. They can have impacts on the caregivers, and they can have impacts on the medical providers. I'll go through some of the central ones. First, in terms of the person with the rare condition, these challenges can pose great difficulty in establishing an appropriate medical home to centralize the clinical care for that person. There may be great difficulty in accessing appropriate care in emergency departments or in outpatient or in inpatient services. Further, there can be insurance-related barriers in having coverage for testing, procedures, clinic visits, and still other healthcare needs. And the consequence of all of this is that the affected individual, the individual having the rare and or complex clinical condition, may not receive full or adequate care. Just as there can be impacts on the person with the rare clinical condition, there can be impacts on that person's caregivers. And these range a gamut of significant types of sequelae. There can be emotional consequences, frustration, sometimes anger, because of inadequate care that their loved one is experiencing. A different type of impact is that the caregivers are often being put in the position of being an expert. And this can cause stress on that person or the other family members. And it can also cause distorted interactions with members of the healthcare team. Finally, and often not given enough consideration, is that there can be impacts on the actual healthcare of the caregivers and on family dynamics and on the family income as a result of all the stresses that the system poses in trying to obtain care for the person with the clinical condition. There can also be impacts on medical providers. One of the most significant impacts is that healthcare providers, who are usually really well-intentioned individuals, often do not have adequate time and often do not have appropriate resources to provide optimal care for the person with the rare or complex clinical condition and to provide care for the full family. So given these types of challenges and given these types of consequences to the person with the rare condition, to their caregivers, and to the healthcare providers, what are some of the solutions, both short-term and long-term, that might be put in place to improve the situation for all parties, especially for the person with the clinical condition and his or her family? And I can't pretend to have every solution for all of these very significant problems, but I'll pose some general solutions that I think will be helpful. And my partners today will go into some of the specifics in very beautiful ways to provide hope for how we can improve the system. Some of the short-term solutions include the following. First, it's absolutely essential that anyone who has a rare or very complex clinical condition have at hand a concise, up-to-date overview of his or her medical history and be able to provide that to any clinical team that needs it at any point in time. And that overview has to have a succinct review of the clinical history, the current status of the health of that individual, medications and allergies, and the general overview of the plan that's needed and who's been participating in the healthcare and their contact information. Paired with that, there should also be a concise, up-to-date overview of the rare clinical condition. One can't expect every healthcare provider to know about every rare condition that's out there, but there are very good summaries. And so one should have at hand a review of the presentations, natural histories, acute and chronic management of a particular condition. And these are available, and they should be presentable to any healthcare team at any point in time, along with the person's clinical history. Telemedicine can be a very helpful part of the answer for some people. For those persons, for example, who have motoric handicaps and cannot get to clinics very easily because of those types of handicaps, or who have financial handicapping situations and can't access healthcare for those reasons, or who are in underserved areas such as rural areas that don't have the types of expertise, telemedicine can be very, very useful in a lot of instances. It's very important to have a well-developed personalized care network. This can include family members or others, but it must include people who are knowledgeable and committed to providing assistance in the health care of the person with the rare condition. And those partnerships should also involve members of nursing and the primary care physician. And those types of relationships should be bidirectional, because the person with the rare condition and his or her family members are in fact experts about their clinical conditions, and they can provide wonderful feedback that will help educate the primary care doc and the nurses, and they in turn can then be more educated and can be better advocates. Those are all some useful, relatively easily implementable short-term solutions. What about some longer-term solutions? And here again, I can't provide every single long-term solution. I don't know them all, but I know some. And my partners in today's webinar will elaborate on many of these ideas. One-term long solution is for every member or every person who has a rare clinical condition in their family, build into their individualized educational plan a medical transition plan that utilizes local resources, such as a primary care doc, a school nurse, and ideally a transition care team. And my colleague, Julie Corder, will in particular speak to this issue. It's very important also to develop a very committed and knowledgeable care network for the affected individual, so it isn't totally the responsibility for that individual and his or her parents or siblings to advocate for their care. Having a full network, including a primary care doc and a transition team, is essential. Looking at this from a different angle, it's very important in terms of the healthcare system for us to make sure that there's improved education of healthcare students and of current practitioners, particularly in two areas that are really impactful and important for persons with rare conditions, those being medical genetics and metabolism, because right now there's too little of the teaching of medical genetics and metabolism in, for example, medical school curriculum. There also must be an expansion within healthcare education, especially in medical school education, in an area that I call meanings of disability. And what I mean about this is, in addition to schooling students about anatomy, physiology, pathophysiology, how to make a diagnosis, what medicines to give, and when to apply surgeries, all of which are hugely important, one also needs to incorporate in contemporary healthcare education meanings of disability. In other words, teaching about the lived experiences of persons with disabilities, of persons with rare or complex clinical conditions, because it's only by doing so that one can fully approximate the best medical care for persons and for families who have a loved one who has a rare condition. We also need to work on increasing the workforce in a couple of areas. For example, increasing the workforce of medical geneticists who deal with adult patients, and of healthcare link workers. And finally, the last thing that I would like to mention is reform of the healthcare insurance system is needed, because right now it's blocking adequate care, not just during times of transition from pediatric years to adult years, but earlier times and later times as well. And we need to increase the ability of families to share their knowledge of their experiences and their resources with the primary care physicians and team, and for those people to incorporate their knowledge into their clinical practices, into advocacy. And still another long-term solution is to increase the utilization of telemedicine, which COVID has taught us can be a very helpful methodology to be put into play, but can be brought even greater play in terms of transition of care from persons from pediatric to adult care. And at this point, I'd like to thank the organizers of the conference and turn this next section of the webinar over to my brilliant and wonderful colleague at the Cleveland Clinic, Julie Corder.
Thank you. That was a wonderful introduction. I am Julie Corder. I'm a pediatric nurse practitioner at the clinic, as Dr. Nitovich said, and with the Department of Complex Care right now. I take care of kids with multiple chronic medical issues and oftentimes who have a dependence on technology also. I am thrilled to speak with you about a topic that is near and dear to my heart and has been for many years. First of all, if you're attending this webinar, I imagine that you have a young adult who is approaching the age of majority and transitioning to adult care, and congratulations. This is a huge success and reason to celebrate. It is the culmination of many years of incredible, diligent care, advocacy, and hope. And with all of the patients that I've cared for, whether they be healthy, typical young adults or those with chronic medical conditions, it is a very emotional and daunting time for all families. The one word of caution, though, that I will give to you is that by avoiding the subject, not talking about it, and procrastinating, it won't prevent it from happening, and it'll oftentimes result in a less than positive outcome. If you start early, talk about it frequently, are thoughtful in your planning and communication, you will definitely have a much more positive outcome and experience going through the transition process. And that's the other thing that I wanted to mention. Lots of folks, including healthcare providers, confuse the transition process with the event of going to a new provider, which is the transfer. Transition is a process that oftentimes it takes years to complete. Transfer is a one-time or multiple-time office visit with that new provider. In order to prepare for that process, I would encourage you to get as much information as you possibly can, not only about your child and their health condition, but as well as along with that, providers who are possibly available on the adult side to take care of your young adult, and speak to others, other parents and other families, as well as use the internet. It really is your friend. There is a vast wealth of information that's available, and you can easily get caught up in all the information that's out there and get lost for hours and hours on end. Planning for the transition is something that is really important. You do have some control. This is the plan that you're putting together for your loved one, and planning it and revising it and kind of revisiting it, I would highly encourage that you do, because you can never start too early. It's never too late to start. And as Mac and Linda will also support in this statement, that all youth can participate. Everyone can participate. We may need to make some adjustments for age or developmental level, but really all young adults are able to participate in this plan for their future. So one of the other positive things that happened from COVID is that our institution identified the need for having a thoughtful process for caring for patients throughout their lifespan, from birth to death, and they wanted to make sure that patients felt that they were being respected and cared for in a positive manner. And because of that, I was approached along with a number of other folks to serve as content experts or to help guide this process. One of the first things that we did was created a vision statement for our program, and I've displayed it here for you. This vision statement, although is one sentence, had multiple iterations. We pulled the opinions on other healthcare providers, social workers, nurses, administrative folks, adult providers, pediatric providers, as well as subspecialists. And most importantly, we got the input from our patients and their caregivers. We formed a focus group, which is still working with us and will be throughout this entire process to review the different policies or positions that we put into place and to help guide this plan for our institution. The one site that I really highly recommend that you visit is Got Transition. Got Transition is a federally funded website, which is a wealth of information, not only just for healthcare providers and institutions, but also parents, teachers, researchers, and policymakers. The third version of this website was launched in July of 2020, and it has an incredibly robust search function. If you click on the magnifying icon and just type one word in, like if you type in readiness, you will then be linked to the different variety of readiness assessments and other tools that they have available to help guide the transition process. One of my other favorite pieces of information on this site is the toolkit that they have for parents and families. It addresses a variety of circumstances for those young adults that'll be able to be completely independent in adulthood, and also those who will need some help with making decisions and managing their lives. And my partners, Mac and Linda, are going to go into much more detail on how to kind of determine what that shared decision-making picture should look like. Since we utilized Got Transition's approach to transition, we also utilized the 6 core elements, which is their stepwise approach and timeline for transitioning young adults. We started mentioning, and we do this now, we mentioned the idea of transition to youth that are age 12 to 14. We want to plant the seed. It's not anything that's going to happen in the, next 6 months, but it's something that we want everyone to be aware of so that they can start planning and anticipating. At age 14, we are now asking that every youth on an annual basis complete one of our readiness assessment tools, which we've built into our electronic medical record. We used the Got Transition Readiness Assessment. And once the youth completes it, which we were able to send a link so they can do it electronically prior to the visit, those responses are recorded in a flow sheet so that we can go back and track chronologically what they identified as gaps in knowledge in the past, and to also help create goals for upcoming visits and upcoming years. Tracking and monitoring or keeping track of those flow sheets and where we are in the transition planning process is important, and we're working right now on building that into our electronic health system. Finally, step number 4 is what Dr. Nitovich was mentioning, that developing that healthcare transition plan and having that robust medical summary so that if you do have a condition that is not all that well known and requires specific medical care, it's great to have your providers help to coordinate and put that information in a concise fashion so that if it needs to be obtained urgently or quickly, it's available. With the new electronic medical records, we have a patient portal called MyChart. And so when we plan for the healthcare transitions, we oftentimes create a document within that portal so that when a patient travels, they just need to have access via phone or computer to their medical record, and they can bring up their own healthcare summary. The 5th step and core element is transfer of care. That's not the final step. It's one prior to the final step. The transfer of care is sending that young adult off to the adult provider and providing a warm handoff. And by a warm handoff, what I mean is we have utilized, COVID has really allowed telehealth in our institution to take off. And it has opened doors, just as Dr. Nitovich was saying, for individuals who had a hard time getting into our center. They have mobility issues, but we can actually link that young adult with our team and also their oncoming adult team and have a visit where we can talk about all the little nuances that went into making them the person that they are now and introducing them to that new provider who will be taking over their care. Once that visit is completed, we then go back for step number 6 and ask them to give us some feedback on how the process went and things that we could do to improve it. These are a couple of the marketing pieces that we created as part of this project. We, again, used Got Transition for our content information, and then we shared this with our patients and their families and got their input on how it should look and how it should read. We wanted to keep it simple, concise, and this is information that is provided to the family. The one on the left is a marketing piece that we have displayed in the clinics, and the one on the right is a tear-off sheet now and also information that can be added to the after-visit summary so that if they lose the piece of paper, they can still refer back to it. I'd like to share a couple of patient stories with you. I think it helps to personalize things a little bit more and gives you some ideas on how to process things. Jamie was a little girl that I met when she was a toddler. She developed renal failure when she was 2 years old and was on peritoneal dialysis for a number of months, and then received her first kidney transplant after a few months on dialysis. She has since had a second transplant when she turned 18. But these are some pictures of her when she was younger and growing up. She had a zest for life, and she attended school. She had an IEP while she was at school so that if she needed to go to frequent medical visits or if she was sick, it would not count against her. We also included in her IEP that she intended on going to college after she graduated. She had a wish to become a nurse. So when we created her transition plan, we wanted to make sure that she had knowledge of her disease and the medications, what they were for, and what she needed to know about herself to take care of herself. I started seeing her for a portion of visits at about 12 to 14 years of age. We'd ask mom or dad to step out of the room and we'd have a private conversation, not only to have an opportunity to speak about confidential topics, but also to give her an opportunity to have a chance to have her own voice and to speak for herself, which is really important as an adult. You need to be able to explain what you're feeling and explain changes that you've noticed if you're concerned about your health. We also had some confidential discussions and very pointed discussions about risk-taking behaviors, drugs, sex, planning for pregnancy, and how those events and decisions could affect her transplant and overall health. She maintained that IEP through high school and had the goal to attend college, and so that IEP was able to be carried over to her college years. Prior to her leaving to go to college, because she did live on campus, we created a medical summary in the electronic medical record, and it was available to her via patient portal. We also communicated back and forth with her via that portal regarding lab results, any changes in medication doses. And prior to her leaving and moving on to campus, we received the contact information for the healthcare provider that was going to be at her college health center. We picked up the phone. We had a warm handoff, a conversation with that individual, and talked about any concerns they might have, as well as giving them contact information if they needed to get back in touch with us. She graduated from college, and she is a nurse. She works in the neonatal intensive care unit now, and she's also married a wonderful guy and has 3 amazing, beautiful children. My next patient, Thomas, I met when he was a bit older. I met him when he was about 11 years of age, and Thomas has multiple chronic health conditions that he is followed and cared for by a team of providers. And he is nonverbal, has some intellectual disabilities, and relies on his family for help with his activities of daily living. His mom was very anxious about transition, and she would verbalize that at numerous appointments and asking us, how long we would take care of him. And we had a thoughtful conversation about how his transition, how she would like his transition to go. She decided that she would like to transition his pediatric subspecialist to adult subspecialty care prior to primary care. And so we worked on that with her. When he was about 17 years old, she started going to those adult subspecialty visits and asking those providers specifically who they knew on the adult side that they recommended and thought would be a good fit for Thomas, because he needed help with decision-making and care. We also ensured that mom was knowledgeable regarding how to establish guardianship prior to his 18th birthday. We also our social worker discussed with them ways in which to ensure that we would maintain his insurance coverage, not only for his medical care, but also for equipment and nursing care. We did create a robust medical summary in the electronic medical unit, or electronic medical record, and we provided a warm handoff to his new primary care provider via a telehealth visit. This is Thomas at his last visit with us and outside our building. And this is a quote that his mom shared with me, and it really struck a chord. She was terrified of this process, and the fact that she was able to see that we were communicating, that we were planning, and that we were with her during this process was very reassuring. She is now one of the parents that we're using in our project for our institution at the Cleveland Clinic. She's one of our resources. And she's serving on a committee that I share with Dr. Nitovich, and that is to identify kids that have medical complexity and to work possibly as a consultant team for them to help with the transition process. A lot of kids with medical complexity don't all come to complex care. They're cared for in the community by traditional pediatricians who may not have the same level of supports that we have here at main campus. Our team includes a PharmD, social worker, nutritionist, myself, and one of the physician that I work with. And as a team, we really try to maximize and improve the life of these young adults. And so we want to extend that level of care by offering this transition consult service to all patients. And here are some of my favorite resources for you to utilize. And with that, I would like to thank you for your attention and turn it over to Mac and Linda, who are going to share an even more personal journey with you on their transition. Thanks.
Hi, everyone. Thank you all. We are going to be providing a family perspective, and this is our journey. So who are we? I know we've had an introduction already, but we're going to go ahead and do a little bit more. So Mac?
Hi, my name is Mac Starnes. I am a college graduate from Lynn University. I have a bachelor's degree in multimedia journalism. I am a content creator and a photographer. I am on a team with the National Care Coordination Academy and also serve on the Florida Family Leaders Network.
And I'm Linda Starnes, Mac's mom. And long ago, I worked as a special educator. And then I also worked with the U.S. Department of Justice and the Department of Education. And then I took a little work break for about 27 years. And now I am the statewide family leader at the Florida Department of Health Title V office that oversees in part children and youth with special health care needs and connects with their families as well. That break in time of about 27 years, I was earning a very specialized PhD in my own opinion. I call it a parenting PhD of lived experience because I happen to have two young adults with very different conditions that affect their lives and varying abilities. And as was said, terrific people. And in the meantime, I've also done a lot of advocacy work, various boards and councils and whatnot on healthcare, disability, education, et cetera, and occasional speaker, sometimes with this guy, as well as an occasional writer. And we would like to just share part of our passion about healthcare transition, which we are still involved in as a lived experience moment, but also have a lot of things to share under our belt through the process. So you're going to hear a bit of echo effect from what we heard from the doc and the nurse, because it is a journey. You do need to have an appreciation for the fullness of transition that we all go through, some of them expected and others very unexpected. And just as Julie just said, it's never too early or too late to start in on the process of planning for any of those transitions and future events we know are coming our way. So it was touched upon. There's transitions in all of our areas of life: school, work, community, relationships, and healthcare.
That's right. So we were always preparing for next steps. Or at least my mom was making sure of this. Just like it has been said, transition is a process that happens over time, until you are ready for a transfer to a new adult doctor, and make sure you are healthy when you make the move.
And so Mac is correct. One of the stories that we have to share from a personal experience is he was just getting ready to start transitioning in and transferring over to a subspecialty care on the adult side. And it became apparent that he was going to need a series of surgeries that fell under that purview of the subspecialty area. And everyone decided it was not time to move forward, but to stay under that pediatric care of those who knew him best to carry through with those surgeries. And then once Mac was back to the old Mac Starnes and ready to go, that transition carried forward. And it was a much more stable time for him to go through that process. So from the big picture, not only were we doing this, but about 500,000 other kiddos and youth and young adults with special health care needs each year are going through the transition learning and transfer of care process. And sadly, research tells us that most of them are not prepared. This conversation we are having is to try and increase those numbers and help young people and their families be more prepared, because their families are also not prepared. We never even heard of the concept of healthcare transition until my daughter was getting ready to go to college, and I had a 14-year-old in high school. No physician had brought it up. No one on the educational side had brought it up. And the assumption we believe was that they just assumed families were going to take care of it. And we didn't have a full concept of it all. So we kicked in to learn a lot. Also, that means you need to have, as strong as you can, a family and professional connection with your providers. And it was touched upon just a tad, but I'm going to say, please look for the accredited offices and clinics and hospitals that are in your area that are patient-centered medical homes. There's a stamp of approval that comes with that accreditation, and many offices actually brag about it, that they are that accredited type of service, and they're much more likely to have a strength in being able to provide transition services, much less all-around good care. Another thing about that, never too early, never too late. I actually, because I've been a special educator, we started very early. And those skill sets that are the building block to a safe and healthy transition, things like learning how to make decisions. You can start that in preschool, helping a little one learn how to make decisions. You can help little ones learn about how their body feels with their particular rare condition and how to show where it hurts and how bad it hurts. The different things that you just start, sometimes it's just a natural thing that we go through, but those are those building blocks to learning about their disability and their self-care and preparing for high school and those emerging adult years. Emily and Mac, one other little thing, as soon as they learned how to sign their name, when we would go to the myriad of appointments that we went through, they would go and sign in because they could sign their name on that patient arrival page. And they could carry the insurance card over, or they could provide the credit card out of mom's purse to help pay at the end. So all of those things, those are steps in communication interactions. And then one little sadness and hurdle that to also bring up, but because of this awareness, you know that you're going to need to work a little bit more, that there are disparity issues. Our research tells us, and that's not surprising in our healthcare services, the disparity issues that folks, minority groups are finding, and also those with disability and rare conditions, and accessing adequate and appropriate care. And so just knowing that and having that awareness that the data is out there that tells us that we have those disparity hurdles to overcome just urges us to work even more on those issues.
Here are important skills teens need to develop to help them with transition, to understand their rare condition, and be able to communicate, advocate, and make shared decisions with their providers to the best of their ability.
So I want to underscore that, to the best of one's ability. And this is what Julie showed us in those beautiful sets of pictures of two patients, wonderful patients, gifted patients, delightful people, but they're on a continuum of abilities and a continuum of communication skills and where they're headed in life. So everyone, though, can learn the concepts that they need to learn to the best of their ability. And families will know that. And they have that expertise as well with their kids. What is the best ability for my child to learn about themselves and their self-care and health literacy issues and their health record and building communication skills and learning how to advocate for themselves and say, I don't feel good in whatever their best communication method is, and I need help. Shared and supported decision-making. And these are all important skills to be working on all the way through. And it also supports that whole person transition, not just in medical care, but all of the transitions they're going to be facing as they move to adulthood. I want to point out that there's a picture of My Health Passport. That's an easy one-pager that is many people utilize as a quick snapshot. For some of us, Mac has a 4-page medical summary that's his quick snapshot, but that's just one tool that I can mention to you that's an easy one-pager to take. Also, the whole aspect of telehealth. It's around us, and we hear much about that. And that picture is there to remind me, if you are not fully ensconced in telehealth yet and you want to learn more, Family Voices, the national organization called Family Voices, just came out a couple of months ago with a family-based toolkit on telehealth. And it starts with the very basics and how to prepare for appointments, as well as being in appointment and post-appointment, with a lot of different materials that go with that. So I'm going to just throw that one out there right now. Next are some other considerations.
You can practice these skills and abilities in the school setting and make sure your school planning team is aware of this when it's time to talk about the IEP for the school year. Have your child to be part of their planning process too. This can be an important time where they can use some of these skills. Also, dental and mental health care needs to be a part of the overall healthcare transition process too.
So Emily and Max Starnes went to their IEP meetings from the time they were little and all the way through. They didn't stay for the whole time, but they learned through osmosis and being there, and then they started to speak up for themselves. And by the time they were in high school, they were co-leading their own IEP meetings. If your child has a 504 plan, same thing, have them fully involved. They learn such great advocacy and communication skills. And then on the dental and mental health side, it's just as challenging for those of us to sometimes find those appropriate services. So fold that in with the whole healthcare process. Post-COVID pivot. I call it teletransition. And I'm on a variety of national work committees, and this comes up time and again, that having care coordination and teletransition meetings that help bring all the components together for the warmest of handoffs that Julie and Dr. Nitovich were talking about. That's a great opportunity now, and please advocate for it if that's something that will help your family. Building that strong patient partner with the provider partnership. Ask questions. Be prepared for your appointments. Have information to share with your provider. If they aren't as fully informed as our professionals here today, you have resources to share with them to let them know how one can best access care. Some of those with autism or intellectual disability, they may need some very individualized thought brought to bear when they come in for appointments. Share with your provider what's best for them in accessing care and train them up. And I'm going to have some resources on that in just a minute. And finally, on the legal aspect. And guardianship is a consideration. There's variations on that topic from state to state. And it's a parent's work with their child to make those determinations of where on the spectrum of having those rights and considerations. So there is full guardianship, but there's also something called supported decision-making. That's at a different place on the continuum where there's some need for supports in decision, and it's a legal undergirding. Max Starnes only needs a proxy from a time to time when he is having a surgery, and he signs over proxy, healthcare proxy, to his parents while he is incapacitated due to surgery or major illness. And then when that's behind him, he's his own person. Finally, we want to quickly share our resources. This is a lot, and we realize that you're going to be getting information afterwards from NORD, putting together these resources and more. I just want to point out a couple of quick things. The top ones are more for families to share and to learn more, as well as there's a section for providers. The bottom three, those are specific for providers and learning more about transition and specific conditions, for instance. The Quality Trust in the middle here, it is the National Center on Supported Decision Making. Please do learn about that if that's a new term for you. It's really important as you make those guardianship determinations. So, with that, it was a quick run from all of us, but we hope this is enough to whet your appetite, to encourage you to move forward. It's hard work. But it's rewarding, very rewarding. We had a young man who went away to college, 3.5 hours from home, lived in the dorm, and was able to pull it off 4 years and graduated. It can be done. And they do grow up and they do move on, and we want them to in the best of health. So from Orlando, Florida, land of Disney, we encourage you to keep See, just keep swimming, right? Thank you, guys, and very good health.
Thank you all for your really informative presentations. As a reminder to our audience, we'll follow up with links to all the resources that were mentioned by our presenters today. There was a lot of great information. And to make the most of our time, we're going to jump right into the Q&A and try and get questions answered. The first question I want to pose to Dr. Nitovich, just to briefly respond to, why is the process of transition particularly important for rare disease patients compared to perhaps adults with more typical healthcare?
I'm sorry, Caroline, you're not coming through very clearly.
I'm sorry about that.
Question.
Yeah. Can you hear me better now?
Yes.
So could you respond maybe, why do you consider the process of healthcare transition more particularly important for rare disease patients as compared to perhaps young adults with more typical healthcare needs?
Sure, thanks. That's a really important question. It's important for everybody. Everybody goes through these transitions, and but for persons with rare conditions or complex conditions, it's particularly important because there's a lot of challenges that are inherent in changing, say, from a pediatric healthcare to the adult healthcare. If you have a rare condition, by definition, a lot of people will not be familiar with it, including healthcare providers of different types. And that in and of itself poses a lot of challenges. It takes, as every person on this webinar has mentioned, a lot of planning in advance, knowing that this is going to be a challenge, to make sure that that transition occurs in a thoughtful, very deliberate way, so that even if one does have a rare condition or a complex condition that involves potentially a lot of different types of healthcare providers and specialists, you can accomplish that transition smoothly and permanently without compromising one's care and without putting too much pressure on the affected individual or the family members.
Thank you.
Thank you.
Next, we'll ask Mac, how do you know when it's the right time to let teens take over their appointments?
To me, the right time to have teens take over their own appointments is when they are able to take on that responsibility for their health care. This includes steps like the work of pre-appointment activity, taking care of handling their actual appointment time, and following what they are to do post-appointment as well. It will have to be baby steps in learning all this when they're younger.
And I will say it is a gradual process. Even those baby steps of the parent stepping out of the appointment and allowing their young person to have more and more time individually with the physician and the parent not there being the influence. And then eventually that comfort level of all of the activity. And I think it can be done with many of our young people. Thanks, Matt.
And Linda, perhaps, what would you suggest to parents whose young adult children are fearful of, quote unquote, taking the reins of their medical care?
Well, I can understand that. There's a lot of anxiety. We are all dealing with even more anxiety these days. But I would say try different strategies. The more you can check out some of these resources, you're going to pick up some very specific strategies to utilize. And if one strategy or approach doesn't work, then start moving to another and partner with your young person and the clinician and even staff or social worker. All of those can come together to make building comfort level in that switching of gears.
Thanks. Last question, Julie, if you could briefly answer, how is communication typically handled from one practitioner in the pediatric clinic to the adult clinic? You mentioned phone calls. Is that typical, or do the adult clinics tend to go through hundreds or thousands of pages?
One thing that we have at our institution, which is an advantage, is the electronic medical health record, which is a shared health record, and it's a repository of a lot of information. We communicate via staff message, so an individual message to that provider. We also, as I said, created that electronic medical health summary, which we can forward to them for review, and also telehealth. That is an amazing way to communicate not only with the new provider, but include the family and parent with that visit, so that everybody is available to hear the information as it's being presented. We also encourage return communication from that adult provider if they run into a problem or a question, saying that they can reach back to us to help clarify a plan of care.
Great, thank you. And unfortunately, that's all the time we have because the hour flew by. I want to remind everyone who's listening to the webinar today that you're welcome to share this with others, and you will be receiving the recording as well as the resources after the webinar. I want to thank our speakers for sharing their expertise and experiences with us today. And I'd like to extend a thanks to Estella Spoon Therapies for their support of this webinar. You'll receive a short survey about the webinar, and we encourage you to complete it so you can help us develop future programs. And with that, thank you again for joining us, and please enjoy the rest of your day.
Thank you.